Welcome back to the last session of the EMT transition course. This session doesn't have a lot of content. It'll be fairly short, but what is here is fairly important, and I think is a refresher that we all need to probably go through regularly. So we'll get into this. Mostly we're going to deal with aspects of the elderly. So on the transition sheet that's provided by the Iowa Bureau of EMS, some of the objectives are understanding changes that are associated with aging, psychosocial aspects of aging, and age-related assessment and treatment modifications for cardiovascular diseases, respiratory diseases, neurological and endocrine diseases, and dementia. Now, when I looked at this, I thought, holy cow, that's a lot to cover. But in looking at it, what it's really saying is we need to understand the changes that happen within these diseases, specifically related to the elderly and how they're aging. Now, I know you guys all got education on cardiovascular diseases and respiratory illnesses, as well as the others in your initial education. But specifically how that deals with the aging population was not actually covered. I'm going to apologize in advance. I have my dog here with me this weekend, and she tries to get her 2 cents put in. So if that happens, I apologize in advance. So what we need to do is take a look at the elderly and how our assessment and our treatment is going to change with them regarding these specific areas. Now, just because someone is older does not mean that our assessment is going to change. The steps of that assessment stay the same regardless of the age of our patient. And when we start changing up our assessment for one reason or another, that's when we're going to stand a risk in forgetting something. So I would encourage you to get your assessment down and to always do it the same way. However, in some of our elderly population, let's look at, for a minute, we'll talk just a minute, I'm not going to use a lot of slides on this, but looking at cardiovascular diseases. Now with the elderly, obviously they're going to be at higher risk for cardiovascular disease. So our index of suspicion should be kicked up just a notch with our elderly. Not that the younger population can't also have cardiac issues, but chances of an elderly person suffering something of cardiac nature or respiratory nature is much greater. So we want to recognize that our risk factors are different with the elderly. We also want to recognize that the way that they present may be a little different. Now, our elderly population, part of the aging process indicates that some things change within the body. And one of the things that change within the body is our nervous system. Our nerves aren't able to pick up and receive messages quite as well as they did before. Our nervous system is a little bit delayed and somewhat desensitized as we get older, specifically if you've got a patient that's also diabetic. That has a drastic effect on the nervous system. So when we're looking at cardiac issues, with our elderly population, that chest pain that they may have felt when they were 40 may not be near as severe or may not be felt at all when they're 80. So when you look at your patient, if they're short of breath and they're diaphoretic and they're anxious, and you ask them, does your chest hurt? And they say, no, not really. That does not mean they're not having a cardiac event. So we need to look at the big picture and not be too quick to rule anything out with this generation of patients, because they truly just may not feel what we think they should feel when they're having a cardiac event. The other thing that plays into factor are risk factors with cardiac diseases. Now, as we get older, depending on our lifestyle, our risk factors may go up. You know, if you smoked for 10 years, you run a higher risk of cardiac disease. But if you smoke for 60 years, obviously that risk is going to be higher. What type of lifestyle these people lead? Have they become very sedentary, they're not moving much? Maybe they've gotten into a wheelchair, so they're not going to move. That's going to increase their risk for embolism or blood clots, because that blood is going to pool in those lower areas, like your feet and your buttocks, lower parts of your body where the blood may pool, may coagulate there, may form little clots, and then when they get up and move around a little bit or get a little bit of range of motion going, those clots get knocked loose when our blood pressure goes up and our circulation gets better, and those clots may find their way to the heart, to the lungs, to the brain. So we may end up with a neurological episode, such as a stroke. We may end up with a respiratory episode, such as a pulmonary embolism, which is a clot in the vessels around the lungs. Pulmonary embolism is not a blockage in the airway, but it's a blockage in the blood flow that goes around the lungs. So part of those little alveoli sacs in the lungs that should be exchanging oxygen with carbon dioxide are not able to do that because the blood flow has been stopped. And those frequently are fatal. So the other thing is, if you get a blood clot to the heart, that is going to cause a myocardial infarction or a heart attack. And the part of the heart that would have been fed by that vessel beyond that clot now no longer is getting any oxygen or nutrients, and if something doesn't change, will die. So lifestyle is going to have a big effect with these patients. They're much higher risk for having multiple things going on at one time. So let's talk a little bit about some of these factors in general. Okay, cardiovascular. We talked about reduces the person's ability to feel pain and discomfort. Diabetics in females and geriatrics are at more risk for having what we call atypical or abnormal signs and symptoms associated with a heart attack. So your females, I've taken care of several females who came in and absolutely did not present like they were having a chest pain. They did not have chest pain. They did not have any of the classic signs and symptoms that we were told would happen when they have a heart attack. These ladies came in, one of them had pain just above her wrist in her right hand. Said it was unbearable. She was 53. A few short minutes later, she coded and died. And that was the only sign and symptom she had, that she was having a heart attack. Took care of a couple other ladies. They had bad toothaches. Those also were heart attacks. Another woman I took care of had a severe pain between her shoulder blades and thought she had hurt her back, having some back issues. Turned out those were also a heart attack. So women are just very whamsy-pamsy and all over the board with their pain. Diabetics, because of the process of the diabetic disease on the nervous system, oftentimes will have diminished or different pain with their MIs. And like we talked about, the elderly, the same. So if you have an elderly diabetic female, really not hardly any chance at all that she's going to have typical chest pain if she's having a cardiovascular incident. So we have to keep that in mind, that there is those three segments of the population that aren't going to follow the rules. And just because they're not following the rules doesn't mean we should not pick up on what's going on. So look for those other signs and symptoms that are going to be associated with a cardiac event. Are they short of breath? Do they feel short of breath? Are they sweaty? Are they anxious? Is their pulse rate up? Which isn't always an indicator, but it's certainly something we can look for. What's their risk factors? What's their history? What medications are they on? So when we go through that assessment process, if we always ask the same questions, we're always going to get all the information that we can get to make the best assessment decision that we can make. Okay. So your assessment needs to be thorough. Not that it doesn't with other patients, but with the elderly, it needs to be very, very thorough, because you can very easily miss something, overlook something. So using that systematic assessment is going to be advantageous. And then communicating with the elderly. That's, if you've not been around elderly people a lot, and unfortunately there's a lot of us who haven't, because we don't keep Grandma and Grandpa at home living with us like we did generations ago. Now when Grandma and Grandpa get older and are no longer able to take care of themselves, are no longer a productive part of society, we find a place to put them. And, we drag them out on Christmas and Easter and see them just a little bit. We put them back in their room and we go on our merry way. Sadly, that's true, and sadly, it's the way society is. But communicating with elderly people can be fun. These people oftentimes have a great wealth of knowledge they'd like to share to you. They're funny, they're grouchy, they're smart, they're sad, they have emotions, they get scared. They have a much more real sense of mortality than the rest of us do, because as your body starts to age, you start to realize you aren't going to live forever like you thought when you were 30. And so look at them as real people. Look at them as something of value, and talk to them. When you first come up to an adult person, talk to them in a normal tone of voice. If they can't hear you, they will tell you. And, if they act like they don't hear you at all, then talk in a louder tone of voice. But don't assume that all elderly people are deaf. They're not. And it's a bit of an insult when somebody yells at you every time they talk to you. So communicate clearly, get down on their level, talk to them. Don't talk to their family. Don't talk to them through something else. But talk to them and get the answers from them. If they can't give you the answer, then go to somebody else. But be respectable. Respectful. Well, respectable too, but be respectful. If these people know that you truly care, you will win their trust, and they will confide in you, and they'll open up. If they think that you're just going to ramrod them through another process and you're there to take their money, sock them up with a big ambulance bill, you probably aren't going to get a lot out of most of them. So get down with our elderly people. You know what? A little touch on the hand, a pat on the hand, squeezing their shoulder, making them know that you care, looking them right dead in the eye and telling them, I'm going to stay with you. I'll do everything I can to help you. That goes a long, long ways. So communicate clearly. Tell them what you're going to do before you do it. Okay. Elderly people, especially those that are having some struggles getting around, become very fearful because they are dependent on other devices and other people to get around. And falling and breaking their hip is no longer something that happens to other people. It's something that they fear every day. They can't get up and down stairs. They're not used to moving fast like they used to be. So when you pick them up and put them in a stair chair and wheel them down a flight of stairs, that's scary to them. When you put them on a long spine board and they can't see where they're going, and you carry them, that's scary to them. Even picking them up off the bed and putting them on your cot is scary. So make sure that you talk to them about what you're doing, how you're going to do it, and assure them that you're good at this, that you do this all the time. The other thing is making sure that you communicate with them so that they can help you hang on, because if we try and lift these patients, if they've got thin skin, that tears just like tissue paper. And so if we have them cooperate with us, much less risk of having those skin tears than if we try and work against them. Okay? Now, when you tell them what you're going to do, tell them when you're going to listen to their lung sounds. Tell them when you need them to take a breath. Ask them where their medication is, and ask them if it's okay if you go get it. Ask them about their lifestyle. And, even if you've got time now, if it's a real emergent situation, things are changed. But, see if there's anything you can get them before you leave for the hospital. Because their hearing aids may be sitting on the nightstand, or their teeth, or their glasses. And those things become very important in their day-to-day functioning of life. So if you go tossing them on a cot, whipping them out of their house, and off to the hospital they go, they may be a day or 2 or 3 before they get those appliances or those items that they need just to function a normal life. So take a little bit of time and make sure that you've got everything that they need before you jet out of there. Okay? You've got to be patient with these people. They process things a little slower. They definitely move a little slower. I'm not even technically a geriatric yet, and I'm already moving slower. So be patient with them. Treat them like they were your great-grandmother or your great-grandfather, and be just a little bit patient. The other thing we need to do is avoid tunnel vision. If you've got somebody that's having chest pain, you may have a lot of other issues that you're dealing with other than the chest pain. The chest pain may be a sign of something, but you may have 2 or 3 other things, maybe something even worse that you're dealing with. So make sure that your assessment is thorough and you don't start throwing things out of that things to consider box, that you keep looking at the big picture with these people. Okay, with our respiratory disease, obviously we talked about risks can increase with advanced age. Just the fact that they've been breathing in and out for several decades, that alone tells you that their lungs have probably lost some of the elasticity. They're not able to take in as deep a breath. They're not able to exhale like they used to. Their vessels have hardened up just a little bit, so that gas exchange isn't going to be what it was. Because of that, our circulation's going to be a little more poor, and our oxygenation is going to be poorer. So these patients are going to be not good candidates for capillary refill, and you may struggle getting a good oxygen saturation on them. Now, if their fingers and hands are cold because of that lack of circulation, you may get a false reading on your SpO2. So, again, asking these patients questions, are you normally cold like this? Are your fingers normally blue? And see what their normal is, because it may be something that's been going on for a while. Now, we talked about before with respiratory diseases, there's a ton of things that could also affect the respiratory diseases. Some of the more common ones would probably be congestive heart failure. If you've got congestive heart failure, you're going to have fluid that backs up in the lungs. It is not a respiratory disease, it's a cardiac disease. But the signs and symptoms show up in the respiratory tract. So when the heart can't pump out all of the blood effectively, it backs up. And when it backs up into the vessels that surround the lungs, those little capillaries and those arteries and veins in the lung system, that fluid's got to go somewhere, so it, by osmosis, comes across the membranes and goes into those little lung sacs. And so we end up with a patient who's trying to breathe through a bunch of water. Now, just like if you would blow bubbles into a glass of water, eventually it's going to become a little bit frothy and foamy, and especially when you put it in, add a little mucus or the surfactants and things that are found in the lungs. And a lot of times these patients are short of breath, and I've even seen them to the point that they're coughing up pink sputum because their lungs are so full of water. So respiratory diseases can be agitated by cardiac diseases, right-sided and left-sided heart failure. They can be agitated by things like asthma, in addition to the COPD that they have. Maybe they've got a little bit of emphysema, which can be triggered by a lot of things: smoke, allergens, environmental things, the furnace kicking on, the window being opened. We may have allergies that the patient didn't have before. So we have a lot of issues. Now, you may also have high blood pressure that you're dealing with. You may have dehydration that you're dealing with, which is going to play a factor in their respiratory process. Because when that patient becomes dehydrated and they are breathing, they're not going to have the cilia, those little hairs that are a little bit mucousy that keep the dust and the particles out. Those get worn out. Those get either covered with mucus or they get dried out, and they're no longer effective. So then we're at risk for getting bacteria and viruses down into our lungs. So oftentimes these diseases become a lifestyle for these people. I'm sure you guys have all seen a gentleman around town somewhere that's got his little O2 bottle with him, and he is breathing every breath with pursed lips. And you can just see that he's struggling with every breath to get that air in and out. You know, nobody should really have to think about or work at taking a breath. But unfortunately, we have people in our society that do. So their perception of being short of breath is going to be different than somebody who has never had to work at breathing. And these people, when they call an ambulance because they're short of breath, are probably going to be severely short of breath and really in trouble, as opposed to somebody who doesn't have these issues. Once they get a little bit short of breath, they may call. But these people that call, that live with this all the time, are probably going to be a more urgent transport for you guys, and somebody that you need to be a little more aggressive with your airway care. The other thing we need to consider with our elderly population is the cost of meds, because that can certainly become a factor. I've taken care of multiple patients who have quit taking their meds, or when you ask them, did you take your meds today? The answer is no, and the reasons vary from several factors. Some of them they can't get to the pharmacy to get them filled. Some of them they don't have insurance coverage, so they can't afford it. And then there's a segment of the population out there that are veterans. And unfortunately, the VA, with all of the good stuff that it does, sometimes is not very good about getting meds to these people, and they may run out and have to wait 2 or 3 weeks before their prescriptions are sent to them through the VA. So that sometimes puts them in harm's way. So ask about meds, ask them if they take it, and try and find out if they've been compliant. If you've got that rapport with that patient, they'll be honest with you. So elderly patients, we talked about, can have different diseases and multiple conditions. It's up to us to sort out, okay, this patient is short of breath. Why is he short of breath? And look at that. Is it that he's hypoglycemic and not hyperglycemic, and he's trying to blow off the extra sugar that's built up in his bloodstream, and that's why he's breathing rapid and fast? Is it because he's having a cardiac issue? Is it because he's having a stroke? Is it because he just ran up a flight of stairs because he's been fighting an imaginary person down in the basement all afternoon, and the neighbors just came in and found him, and he's all out of breath because in his mind he's fighting this anxiety because of his demented mental state. Or is it all of it? It could be a culmination of 5 or 6 different things. So we need to make sure that we get a good history on them, extensive history. Maybe not clear back to when they took their tonsils out when they were 4, but we need to take a quick look at their meds. What meds are they on? And then ask that question, are these all the medications that are prescribed to you? Because they may have to pick and choose which ones they take. So if they've got a list of prescriptions, you may want to look at that as well as their bottles that are in the kitchen or the bedside. Okay. You also want to make sure that you talk to them and see if they can give you some good answers. Ask some questions and then listen when they talk to you back. Okay. If your patient knows that you're listening, they're going to tell you everything. If they think that you're just blowing them off, they're going to quit talking. That's just human nature. So make sure that you, give them a nod of your head or look at them as they're talking to you. Even if you're busy doing other things, glance at them or tell them, say, I'm listening. I'm going to take your blood pressure, but I'm listening. So continue on. And then make as good a decision as we can make based on the information that we have. But it is your responsibility to find that information. Whatever avenue or means you have to go to get it, that's going to be a critical part of your assessment in these elderly people. So let's talk about the psychosocial aspect of aging. This does play a big part in it. Okay? Some of the living situations that we may find our elderly people is, as we talked about, we just don't keep them at home anymore like we used to. So some of the situations that we may find are active adult communities. Now, I lived for quite a few years in Arizona, and down in Arizona there is a ton of entire communities. I'm not talking a neighborhood, I'm talking the whole town, like Sun City and Sun City West, where you have to be 55 or older to even live there. And those are very active communities. Their roads are designed to drive either a car or a golf cart on. There's lots and lots of activities for elderly people, and the whole town is built around their age group. They're great. We have some smaller communities in our areas here that are also designated for elderly people that are like that encourage them to get out, be active, socialize with those in their same age group, and live a good, full life. Other things that we have are senior apartments or independent living. And that's when you're living out on a farm, it just comes a time when you just can't take care of all that anymore. So moving into town and getting an apartment where you live, where you live independently and have just a smaller space, but you've got people around you. You're in town. Sometimes we call that congregate housing, where there's sometimes age restrictions on living in these places. You have to be a certain age to be able to qualify to live there. Then we have assisted living, where you have your own apartment, but there is someone there, a nurse or a caretaker that comes by and visits with you and helps you with things that you can't do for yourself. There are Alzheimer's care facilities, and those range from like an assisted living facility all the way down. Sometimes they actually have what they call lockdown units. Those aren't as terrible as they sound, but the patients can't get out because they're at such great risk of wandering off and being lost. And so there just comes a point when you're taking care of someone with Alzheimer's that it becomes more than you can physically do, because it is a 24/7, never-ending, always on-the-clock job. And sometimes people are, not by choice, but are found that the best thing for the patient is to put them in an Alzheimer's facility. I do think that's probably harder on the patient than it is, or the family, than it is on the patient. Because watching someone that you love and that you know turn into someone you don't know anymore is very hard. We have nursing homes. I'm sure we've all been there, picking up patients or taking patients back from the hospital. Home care, home health care is becoming more and more popular. It's cheaper than nursing home care, and a lot of insurance agencies are advocating home care to those patients that would benefit from that. So that's when you would have a nurse come in a set number of times, whether it's a couple times a week or once a day or a couple times a day, to come in and check on you and help you stay healthy and cared for at home. And that's usually in cooperation with some assistance from family. And then hospice care. Hospice care has different requirements and regulations, but for the most part, the patient will meet some criteria that will say that they are at the end of their life and there is little or no hope of recovering, and they'll put them on hospice care. This does a couple things. This changes their insurance status, and so makes a little more benefit money available to them. The other thing it changes is the way their medications can be administered. When a patient is not on hospice, doctors are bound to treat pain medication under one set of rules and guidelines. And so there are limits that they must abide by when they're prescribing pain medication. Once a patient goes on hospice care, those limits and guidelines for the physician change. So it makes pain medication much easier to get for the patient, and it's easier to control their pain because the risk of addiction is there, but if they're at the end of their life, it's not really a factor anymore. And so hospice care is something that we may run into as ER or EMS providers, and we'll talk about that in just a little bit. The last one is respite care. And respite care is simply a facility in which you can take your elderly family member for a period of time. So it's kind of a babysitter of sorts, although I hate to use that term. But it's a place where you can take them for a short period of time. Say you're going to the mountains camping and hiking, okay? And Grandma lives with you. And now you don't want to get rid of her. You enjoy having her there, and she's not a problem, but it's not going to be a good thing to take her to the mountains hiking and camping. So respite care would be someplace that you could take her for that week while you're gone. She'll stay with them, be cared for, and then when you come back home, she goes back home with you. So those are some different living situations that we can come across. Okay. Some of the concerns with elderly, one of them is self-neglect. Sometimes these elderly people become unable to take care of themselves in the manner that they should be, but they're terrified to tell anyone because they run such a high risk of losing their independence. They know that the next step is probably a nursing home for them. And, you know, I don't know of anybody that likes nursing homes, and I certainly don't know of anybody that is looking forward to moving into one and spending the rest of your life there. And I can't imagine how that would feel, knowing that that's where you're going to have to go. You'll no longer have your place. You'll no longer have quiet. You'll no longer have your home. You'll no longer have your things. You'll no longer be able to take care of yourself. You're now going to be a financial burden on your kids. That's tough. So sometimes they stay in situations when they can't afford food, or they can't afford heat, or they can't afford air conditioning, or they can't afford their medications, and they won't tell anybody because of this fear of losing their independence. So the other thing is, sometimes you've got patients, and we do need to kind of hit on this just a little bit, elderly patients that live with family members and are neglected. So it's, you know, we're talking about the elderly abuse then on a dependent elder person. And so if you get into a situation, you may not even actually be going. I remember one time I got called for a patient that was having a miscarriage. And in the process of moving her out of the bedroom, I opened up a closet, and in this closet was a cot. Now, it was not just it was like a walk-in closet, but there was a cot in there. There was a little end table, and it had a little nightlight on it, and Grandma was on the cot. And she had been in there quite a while. She was grungy, she was dirty, she was old, frail, probably couldn't talk. And they had just stuck her in the closet, and it was a beautiful, nice, big home. And that was very creepy, very scary to think that, I don't know how long she's been in there. We'd been in that house multiple times. So we need to watch out for elderly abuse. We want to look at family interactions. Sorry. Hang tight. We want to watch for the family interactions because sometimes, I'm sorry. One second. Sweetie. Sweetie. Okay. Sorry. One of the disadvantages of working from home. Those family interactions sometimes will tell you a lot. It is a crime and it is illegal to abuse somebody financially. And sometimes you may find out that although Grandma isn't abused, you know, she's there, they're taking care of her, but she's not in control of her own money. They're taking her Social Security checks, they're taking her retirement checks, they're taking everything and doing with it as they want to. Or the family members have all moved into Grandma's house, and Grandma's now footing the bill for all the food, all the heating, all the utilities, while these teenagers are running amok. So look at the situation that's there. You know, there's 1,000 different ways people can financially abuse somebody else, or physically and mentally or emotionally abuse an elderly person. It's up to us to detect that if we can. Now, in reporting this, again, it's just like child abuse. You don't have to have proof. You only have to be suspicious. So if you are suspicious, you are a mandatory reporter, and we do need to report that. A good way to report it is when you go into the ER, talk to the ER doc about it. Tell him what you know. Make sure it's written down in your report. And then if you need to call Department of Human Services, that's your next step. All right, let's talk about homelessness and poverty. A lot of times this plays into our elderly. Now, Now, I went to look for some statistics, and unfortunately, the latest statistic that is out was 2007. But in 2007, approximately 3.5 million people, 1.33 million of those were children, are homeless in every given year. Now, it is estimated that in the year 2012, this number had doubled. So we're looking at potentially 7 million people in the United States of America that are homeless. This is a huge population, and it does have some drastic implications on EMS. So let's talk a little bit about homelessness and poverty. Okay? Oftentimes the two go hand in hand, not always, but oftentimes. So are all homeless people poor? I believe the answer to that has to be no. There was an article done in my hometown in Colorado, the newspaper. There was a gentleman there. There's quite a large number of homeless people in my hometown because it has a very moderate, mild weather conditions. And so there's a ton of homeless people, and you can see them. They take turns on the corners. They all share their signs. They have shifts. And the newspaper did an article on this one gentleman that was homeless, and he was panhandling for money. But for whatever reason, the reporter followed this gentleman home on several different occasions, and he lived in a very nice home. So although he appeared to be homeless, he dressed homeless, he looked homeless, his signs that he held up said he was homeless, he went home every night to a very nice home. And a couple of different times was actually seen in nice clothes, dressed up, and driving a car. And whether that car was his or not. Of course, at that point, he quit talking to the reporter. So, some of them have enough money to take care of themselves. Some of them are truly homeless and destitute and without. Some of them are homeless by choice, though. Now, a couple different times, my ex-husband's employer offered homeless people jobs. He had some jobs that needed to be done, and he offered them jobs for pay and was promptly declined. They said no way would they work for money. They made plenty of money doing what they were doing. So some of them are homeless by choice, and they choose to live that way. They don't want to work. They like the lifestyle that they're living. Some of these people have issues, whether it be mental illness or psychosocial issues, that they just don't fit into society. So fitting into that colony of homeless people works for them. It's not the best, but they're safe there. People understand them. They're amongst people that understand them, and that's where they choose to live. So not all people are homeless by choice. Not all people are there because of choices they make. There are some people, there was a statistic out, and this has been quite a number of years ago, that said that most of America is 6 weeks away from being homeless, meaning if your income stopped for 6 weeks, you would not be able to meet your bills and stay living where you're living, or be able to accommodate housing for you and your family. That's a little scary, and I thought, oh my gosh, that can't be me. But when I went home and calculated, we had 2 young kids, we were mortgaged to the gills, and if we had to have gone 6 weeks without a paycheck, I think that would have been us. I don't know that we could have recovered from that. So, if dad, working hard, construction worker, family, guy, father of 3, Let's say he has an autistic young man at home, and so mom stays home to take care of him. They're just barely making ends meet, falls off the roof and breaks his leg. Really good chance they're not going to stay living where they're living. So sometimes people are there just because of a bad break in life. So the healthcare issues that we could deal with on these people really are much more varied than people who live in a normal living situation, because now we're dealing with environmental issues. Now in the Midwest, that's an issue. It's hot in the summer, which is something to deal with, but the winter months are just something that would be very difficult as a homeless person to live in. I don't even know how you would do it. So we may find those homeless people that get caught out in the cold weather, or that get caught out in the bad weather and suffer because of that. They're going to be, because of their living environment and situations, much more, exposed to communicable diseases. You know, they don't have the ability to keep their food clean. They don't have the ability to make sure everything is refrigerated. They don't have the ability to take care of themselves and protect themselves like those of us living in a normal home would do. We're also looking at, because of their living situation, a lot more anxiety, a lot more depression issues. Now, it's kind of like, you know, which was first, the chicken or the egg? But, you know, are they homeless because of their depression and anxiety? Or are they depressed and anxious because of their homelessness? Probably a little of both. So sometimes healthcare issues, talking about mental illness, you know, do the healthcare issues cause the homelessness? A lot of our homeless people are vets. And, you know, when they come back from Vietnam or Iraq or Afghanistan or wherever they were, especially those that saw active combat, they no longer fit in back here, and they struggle with that. So now, you know, they didn't fit in Iraq. That was a horrible place. I'm just taking this for example. And they come back here, and nobody back here understands. They don't understand what they're going through. They don't understand how they feel. So they don't fit in here. And, you know, we've all seen the reports. We've all heard of issues with returning vets. It is very much an issue that needs to be addressed. But unfortunately, you know, post-traumatic stress disorder, some of these people had mental illness to begin with, and now it's exacerbated by the PTSD. Some of them have developed mental illnesses since they've come back. And, you know, they kind of congregate with other people like that because that's who understands them, and so they end up homeless because they can't function in society. They can't keep a job. They can't control the angry outbursts. They can't, you know, they just always have that restlessness about them. Makes it hard to maintain a home and a job. Sometimes financial pressures of healthcare issues. And say we've got somebody and they've got some serious healthcare issues. I've got one young gentleman that I know that is a veteran, and he came back with a disease, a syndrome, and this syndrome was actually caused by a situation in the service. He was overseas at war, got into some bad water, made him sick, and now because of that, he's got this ongoing huge medical problem with a ton of financial obligations that go with it, some of it which are covered by the VA, but not all. And so he's got a lot of financial pressures on him and will have for the rest of his life because of a healthcare issue. The other thing is children. You know, sometimes we have families that fall into this homeless situation that have kids. And so now all of a sudden we've got a homeless mom and dad and these children, and they do not want to give the kids up. And so these children become homeless. They end up living in their car. They end up traveling around so social services doesn't find out about them and take the children away. So lots and lots of issues with homelessness. It is said that between 90 and 99% of all homeless people are armed. Okay? And they live in that defense mode every minute of their life. Now, as we talked about before, a lot of these are vets. So if you get called to a person that's lying on the sidewalk unresponsive, okay, you go down and he's lying over on the side next to Walmart, next to the building. Okay. Obviously, the first thing we're going to do is make sure the scene is safe, and then we're going to go see if he's responsive. And to do that, we've been told, you get down on your knees, you tap their shoulders and say, hey, are you okay? If he's a veteran, and he is armed, and he is just taking a nap, you've now just scared the life out of him, and whatever he's armed with is going to come out. So if you're on your knees and he reaches up and grabs a hold of you, you're screwed, okay, for lack of better terms. So it makes sense. Now, I am not telling you to kick homeless people. That's not what I'm telling you. But if you walk up and you don't know if somebody's responsive or not, could you take your foot, tap the bottom of their foot, and say, hey, buddy, are you okay? And give them a little nudge there. That way, if they wake up, you're not in their face, and they don't hurt you when they didn't intend to, and you don't get hurt when you didn't intend to. If you do need to get down next to them, get down next to them with one knee up. So you can push off in them because you're already halfway up. Don't get clear down on both knees. One knee up and tap and shout. And then if you get no response, you can do your sternal rub. And once you've assured yourself that they are unresponsive, then your defenses can go down. But make sure that you don't put them in a position that they end up hurting you when that's really not what either one of you did. Give them their space. Don't get in their face. Because, they could be tired. They could be drunk. And they could be in serious need of your help. So make sure you understand that all of those are possibilities. Okay, I got a couple of calls for you, and then we're going to call this done. Aren't you glad? You're dispatched out to a rural residence for a 44-year-old man complaining of chest pain. Scene is safe. The wife meets you at the door and takes you to the back bedroom. Okay, so do we have a plan? What are you going to take to this call? Okay. Now, typically we think, okay, we're going to take our stretcher. We're going to take our jump bag. We'll throw on a bottle of oxygen. And we'll hop in and get it because chest pain we're going to be transporting right away, correct? All right. So you go to the back bedroom, you find a 725-pound male lying on bed. He's obviously in pain. He's diaphoretic and clutching his chest. Okay, does this change our plan? One has to look at their cot and say, okay, will our cot even tolerate a 725-pound male? Will he fit on there? I don't know if you've ever dealt with a 700-pound person, but will this person even fit out the door? Can you get him out the door? Do you want to stand the cot all the way up? Most of the older cots are weight limit is 500 pounds. Now there are some other ones that have a higher weight limit. Your hydraulic cots have a little bit higher weight limit. There are some specific bariatric cots that have a higher weight limit yet. So look and see. Now, a lot of this that I'm throwing out is just going to be food for thought for you to take back to your department. because these are issues that we could deal with, and we need to have a plan beforehand. Okay? So if you get out on this call with your department, what do you need? Is your cot even going to work? Do you have enough people to lift? How are you going to lift him? What equipment are you going to use? The other thing we have to think about, are there legal responsibilities to providing appropriate care to patients of this size? The reason I throw this out there, in northern Iowa, there was a gentleman, and I think he was in the 800-pound range, was very short of breath. The volunteer department got there, and he was lying on a mattress on the floor. They could not get him out the door. He was in an emergency situation. He could not breathe. So one of the responders stayed with the patient. They called the fire department. The fire department came in and actually cut a hole in the side of the bedroom that would allow them to move the patient out onto the front porch. Another group ran down and they rented a moving truck. They took the scene lights and the generator from the back of the fire truck. They put them inside the moving truck. They put down a tarp and plywood, and they pulled the patient out of the bedroom, across the porch on a tarp and a sheet, across the porch, over the plywood, and up into the moving truck. 2 paramedics rode in the back of the moving truck with him and attended to him with others helping out as needed with the lights in there, and they took him to the hospital that way. They called in advance to make sure the hospital was ready for them with the equipment that they needed. When it was all said and done, the family of this patient sued that EMS department for cruel and inhumane treatment of their family member and won. And my question is, what could they have done differently? What other plan could they have made? And I don't know the answer to this, but that was rural northwest Iowa. It could just as easily be rural southwest Iowa that happens. We live in a society, especially if that patient did not turn out well, we live in a society that's looking always to blame somebody else. And so maybe talk to your department chief, talk to your city council, talk to your medical director and say, let's get a plan in place so that if this happens, because it may not be somebody that lives in your area, it might be somebody that's visiting. And if they should suddenly become very sick while they're in your care, and you now have to deal with a 600-700-pound person, that changes everything. So this would just take it back to the table, food for thought, start looking at some of the impacts that this is going to have on your department, on your equipment, look at protocols, look at procedures, look at statutes in your city, statutes that are in the state, and see where you're going to land with this, and maybe talk to other departments and see how you can pull this together. Maybe take it to your county EMA and say, okay, we've got this issue. How are we dealing with this, and do we have the best plan possible in place? We do have a legal responsibility to take care of those bariatric patients, or those large patients, with the same level of care that any other patient would get. So, and I'm sure that's where the lawsuit came in. Most of our patients don't get transported in a moving truck and don't get drug out on a tarp. So the question is, did he get the same level of care? So look at that and see where you stand with your equipment, and if you're even able to take care of these people. And if not, what kind of plan can you put in place to make sure that they get care? Okay. in our society today, we have a lot more really sick people living at home than ever before. In the past, we had, I know back in my hometown, there was a big compound, and it was called the state home. And anybody that was severely mentally retarded, even not severely, but somewhat mentally retarded, or not really able to be taken care of at home, went there. That compound has since closed, and all of those people, thousands of residents that used to live there, are now living in other places. So they're living in group homes. They're living at home with their family who are trained to take care of them. They're home with home health coming in to take care of them. And because of that, we're going to get called to these patients, probably more often than ever. So we've got patients that are technologically dependent. They're dependent on a ventilator. They're dependent on a balloon pump. They're dependent on some type of technology or device to live. We're dealing with patients that are living in a home. They're on hospice. They're terminally ill. And we'll talk about that in just a little bit. You're going to take care of people that have tracheotomies or breathing tubes that come out of their throat. They work fine. They keep people alive, but there are issues with them. So when they don't function right, we may get called for that. We've got home care issues. And how does EMS play into that? You've got patients that have sensory and deficit loss. I like to throw into this category as well patients with language barriers, because I've frequently been called to take care of somebody that does not speak the same language I do. And although it's not a deficit or a loss, it certainly is a barrier. And we've got people that are developmentally disabled, Down syndrome people, mental, we don't use the term mental retardation anymore, but mentally challenged to different levels. And so you're going to find that we have to deal with all this. So obviously, if they have got issues that put them in any of these categories, their healthcare risks are going to be different than that of a normal healthy person. So there's issues that we have to talk about and learn about with these. Now, I know there was a child that moved in to our area that had Genesis imperfecta. He was 4 years old. Genesis imperfecta is a condition in which their bones break very, very easily. So when this child moved into our response area, his parents got in touch with us, and they gave to us a protocol that they wanted us to follow should we ever get called out to this child. And basically telling us, don't pick him up, don't move him, don't do anything, because you'll break his bones. Simply by lifting him, you could fracture a bone. So it was nice that they did that for us, but sometimes we don't have that luxury of them doing that, and we need to recognize that we're going to have these people. So if you know somebody in your area that has a condition, encourage them to get in touch with the EMS agency and the hospitals and let them know about that so that we can better take care of those people. Maybe contact your clinics in town, your hospital in town, and ask them to please contact EMS if they have a special situation. Maybe this would be a good thing when you're doing fundraisers and stuff. Maybe print up a flyer that says, we'd like to better serve you, and by doing so, we would be willing to keep any records or notes on file, obviously secured, of you or your family member if you have a special situation that you would like us to know about before we get to you, in case you were in an emergent situation, in case they're in a car wreck, or in case they're in a family's home or something. You would have this on record and could access it Just a thought to throw out there. I think it's a good process. There's some implications with security issues and confidentiality issues, so there would have to certainly be some intervention there from your legal department before you do that, but makes for better patient care, I think. Okay, you're dispatched out to a home with a 9-year-old boy who's short of breath. You arrive to find a 9-year-old male patient who has a tracheostomy. His aunt tells you he's having trouble breathing. Okay, now aunt does not live there all the time. So, aunt's taking care of boy who has trouble breathing. Aunt calls you. You show up as an EMT. Can you treat this patient? He's got a trach. Can we help patients with trachs as EMTs? Do you have a protocol for that? The answer to that should be yes. Okay. A couple different things with trachs. Now, you can't do deep suctioning as an EMT, but you can certainly suction this patient, and just not go deep, but you certainly may be able to suction something out. Okay. Otherwise, do you have resources there that you could utilize? Is the aunt there? And shouldn't she know maybe how to take care of this trach if mom and dad left her with him? So sometimes parents just get shook up, or people that are there get shook up, and they don't think through, what can I do? They're not wired like us that we just jump into let's fix this problem. They just call 911. So maybe get the aunt. The normal way that family members are trained, and if you had advanced level care there, they would do this as well, is put just a little bit of saline down in that trach and then suction it out. Helps to loosen up some of that mucus. So maybe with a little coaching and questions, you could get aunt to do that. Otherwise, can you put a BVM on top of a trach and help this little guy breathe? Yeah, they fit right on top. We talk about it all the time in EMT class, but we rarely get to see it or do it. So if he's having a hard time breathing, could we assist him a little bit? Could we do some assisted ventilations with him? You bet. Put that BVM on there, squeeze the bag just ever so gently, and when that patient takes a breath, you'll feel that bag start to suck in under your fingers if you're squeezing it just a little bit. And when you feel that, go ahead and help him breathe and help him out. Can we put a little oxygen on him? You betcha. Put some oxygen on that BVM and help him out. Okay? So as an EMT, you're not helpless in these situations. And we think trach, oh my gosh, that's paramedic, that's advanced level. Nope, it's breathing. And you guys as EMTs are very good at helping people breathe. Okay? There's lots of other situations that you might encounter like this. So again, that goes back to doing some brush up on this technologically independent and finding out what your protocols are for those areas and how am I best going to be able to treat this patient. Let's say you get in there and you've got to get on a ventilator. Okay? For whatever reason, his sats are in the toilet. He's blue, he's obviously short of breath, and he can't breathe. Can you do something with the ventilator? I know as EMTs you're going, nope, never been trained on a ventilator. Okay, then take it off. Can you ventilate a patient manually? Then do that, because it might be the ventilator that's the problem. It's not always, because it's technology, always going to work right. The problem may be with the ventilator. So take it off. Put your BVM up there. Those always work. Okay? If they don't, we have a spare. Put your BVM on and try and breathe for this patient. That's going to do a couple things. It's going to say, okay, A, the ventilator was the problem, or B, it isn't. Okay? But you're going to be able to judge how much resistance you get or compliance you get with each breath. You know, is this patient hard to ventilate? You're also going to be able to judge how much pressure you're having to produce on that vague valve mask to get the chest to rise? Am I getting equal chest rise with X amount of pressure? And you know, if that doesn't work, there's other avenues, but you can get some oxygen to them, and you can get a lot more information by just getting rid of the technology sometimes and getting right back to the basics. Okay, last call today. You're called to transport a cancer patient to the ER. Upon arrival, you're met by a distraught wife that tearfully pleads with you to take her husband to the hospital where he can get some help. When you go to the family room of the house, you're met with a thin patient in a hospital bed attended by a hospice nurse. The nurse tells you that you're not allowed to do anything with this patient because he is in hospice care. The wife pleads with you to take him to the ER. You are caught in the middle. So what's your plan going to be? Whoops. Okay. I've been on this call. This is tough because the hospice nurse is saying, absolutely, you are not taking this patient to the ER. Not going to happen. And they're saying that because that's what they've been trained to do. They're trained to be with these patients to help them to the end of their life. Okay. That doesn't include a trip to the ER because there's really nothing they're going to do for this patient in the ER. So really, who is your patient in this situation? Okay. Honestly, the patient is the wife. She's really struggling with this whole process of losing her mate. So there can be quite a conflict that would develop between the hospice nurse and the EMS because EMS has a duty to act. They have been called. Hospice also has a duty to act because they've been employed to take care of this patient. So this is a situation which won't benefit from getting into a screaming match with one another. So this situation probably needs to be turned back to your medical director or to call the patient's physician and get him involved. But perhaps a better way and more proactive way would be to have a plan in place with your hospice agencies in your area that if by chance the wife calls or the family members call 911 for a hospice patient, what is the steps that should be taken? This way you guys have both made a plan. Everybody knows how to act, how to react. You're working as a team rather than working at opposite ends of the spectrum. So I encourage you to get with your medical director, get with your hospice agency, and find out what the best way to work with this situation, because there's healthcare aspects, obviously, but there's also insurance aspects that need to be considered. So this would be a good planning session for you guys, and see what you can come up with, and come up with a plan, because this is a difficult situation, especially when the wife is standing there looking at you for help. So, alrighty, you are finished. You've got one more quiz to take. We hope you learned a little bit in this process. We are glad that you chose Iowa Western for your education. So there'll be a quiz over session 3. Finish that with an 85% or higher. There'll be a short course evaluation. That's just where we'd like to get some honest feedback from you. And then your certificate will be available for you to print. So we ask you to share this course with your friends if you enjoyed it, and enjoy your transition and your new status as an EMT.